Hello and a very good morning to all of you all. And let me begin with wishing all of you all a happy Dasara. I just need a heads up with respect to if you can hear my audio nice and clear. Once I know that, we can start off with today's session. So if you're watching us on YouTube or if you're watching us on Facebook, just put it in the comments that my audio is loud and clear so that I can start off with today's session. All clear. So thank you, Ashish. Ashish is telling that it's all clear. So let me invite our guest for today. He's a very special guest. This is the first episode of the second day of the 32-minute podcast launch, and we have with us Dr. Rajeev Chitguppi. Hello, sir.
Hi, good afternoon.
Yeah. Good afternoon. So I wanted to say this that the topic of COVID 19 was followed by many people when it started its course in India. We have no doubt about that. Many did a lot of research and spoke on it for a while, but then later on they left it. However, there was one person who followed the topic persistently. His updates were consistent, clear, and evidence based. I have no hesitation in saying that there is only one person whom I trust unbiased when it comes to updating my knowledge about COVID 19, and that is Dr. Rajeev Chitguppi. Truly the trending dentist. His tweets reflected the clarity of his thought process. Sometimes, in fact, I have to remind myself is he a periodontist really, or is he a microbiologist or an immunologist? Because he's so passionate about his research, and it's seen in his tweets and his posts everywhere, even in his publications. So, please join me in welcoming Dr. Rajeev Chitguppi for the first episode of the 32-minute podcast launch event, day 2. Welcome to the show, Dr. Rajeev.
Thank you, Dr. Mayur. It's a great pleasure to be with you in this show.
It is
And
my
looking
honor
at the
and
topics
pleasure.
you arranged great topics, great sequence, and I wish you all the best.
Thank you so much for that. Even your topic is really interesting. So, Dr. Rajeev Chitguppi has a very
And
interesting
I love
topic
this.
today, and it's titled like this.
And I
Yeah,
love this.
your risk of yeah.
This
I'll just say the topic. Your risk of death if you get infected with coronavirus now is probably about half of what it was in March or April. The question is why. It's such an interesting topic. It's just so picky and catchy. I really love the title that you've kept.
So, what happened was earlier, the way we looked at the disease, the way we understood the pathogenesis was different. And now our understanding has improved so much in the last 6, 7 months. Initially, it was exclusive and respiratory illness. We used to think which virus affects our upper respiratory tract, which virus affects our lower respiratory tract, and coming to SARS-CoV-2, it affects both upper and lower respiratory tract. So, doctors, physicians, everybody, all COVID specialists used to treat the patients from respiratory illness point of view. And
Right.
as our understanding improved, then they realized it need not be a respiratory illness. There is so much multi-system involvement associated with it. So then they realized the importance of handling the clots, the thromboembolism factor, the
Yeah.
cardiovascular factor, and reducing the cytokine storm. The most important thing, the body tries to protect you initially, but once it realizes that the things are going out of its control, it becomes very, very aggressive and
Right.
non-specifically it starts producing the cytokine storm. Now that we have understood everything, the doctors have mastered the way they are managing it. So if you look at the recovery rate in India, we are almost touching 90%. That is huge. Looking at how we felt the disease was, how dangerous it was, and in 6, 7 months bringing
Right.
the recovery rate up to 90%, that's a great achievement. So I think a lot of credit should go to the doctors
Yeah.
and researchers.
Yeah, I totally believe that. And like you said correctly, a lot of stuff has changed since the inception of this disease. But since we are talking about inception, I wanted to ask what was it that provoked you or triggered your interest into this particular topic that you've been following it persistently since the day one? What was the story behind it?
See, the thing is, I'm not following COVID-19 alone. I was always following, as you said, microbiology and immunology, which were my dissertation topics also in MDS. So you can say that I had a fairly good background for microbiology and immunology because I did a solid thesis way back in 2001, 2002. Since then, I have been following the research topics, and COVID-19 came, and I realized that there are a lot of complex issues in it, which need to be clarified, because most of the dentist population, most of them are clinicians. They need to be told about these things in a simplified way. And what made me take interest was the 15th March article that came in New York Times, which said that dentists are the highest risk profession. So then I
Yeah.
realized, let me work into it, let me identify whether it is true or false. So one thing led to another, and I'm still here doing one thing after the other.
Right, and I believe there was one more topic that created a lot of buzz, and that was that chlorhexidine was ineffective in the initial stages when the disease started. People were doubting if the role of chlorhexidine was really beneficial, right?
Yes, yes. I think that was the main trigger for me. Along with the New York Times article, chlorhexidine was one of the more, because I'm a periodontist. And in the last 18 years, the only thing that I have read is chlorhexidine is the most effective mouthwash among all the mouthwashes. And surprisingly, in the month of February, March, when I was doing research on COVID, I came up with the top Google search result was chlorhexidine is less effective against coronavirus. And I went into the literature, and I came up with an amazing article by Dr. Syed Sattar from Canada. He has made a simple hierarchy: which microorganisms are more susceptible, which microorganisms are less susceptible. And in that I realized that bacteria come in the middle, in the center. Highest level, most resistant, most difficult to kill are the bacterial spores, for which we need autoclaves. And can you guess what comes at the bottom? Least resistant, the weakest one is enveloped virus. The novel coronavirus is the weakest. Then I started thinking, we are dealing with a very weak virus, and we have one of the most effective mouthwashes, chlorhexidine. So there must be something wrong in this perception. So then I went on studying it, because my perio background was always there, research background was always there. So I went on studying the literature. Then I came up with a lot of newer findings. I realized where the interpretation was going wrong. So I realized that the old study which everybody was looking at, they had mentioned chlorhexidine is less effective in 0.02% concentration. Now, if you go into the market, try to find out one product that contains 0.02%, you will not find anything, because products are not available at 0.02%. It is a very, very low concentration. Our mouthwashes are 0.2%, 0.20%, means 10 times stronger. And very soon in the month of April, Lancet published a study in which they showed that 0.05% is enough to kill SARS-CoV-2. It's like if you have chlorhexidine, 0.05%, it can kill SARS-CoV-2. And our mouthwashes are always already 0.2%, means we already have 4 times stronger chemicals in our hand that can kill the coronavirus. And we don't have to destroy the RNA. What are we doing? This is a lipid envelope. It's an enveloped virus. There is a lipid envelope. Into that lipid envelope, spike proteins are embedded. So you destroy the viral envelope, the virus is as good as inactivated. So this lipid envelope can be destroyed by any chemical. You can take povidone iodine, hydrogen peroxide, or any new company from which we keep on receiving messages on WhatsApp, a new chemical discovered that can inactivate the virus. There is no big deal in it. Any chemical can destroy it, but all these experiments are outside the mouth. When it comes to inside the mouth, it's a different ball game.
Yeah.
That's where only chlorhexidine can help.
Yeah, and why would you say that chlorhexidine is the only one that you trust completely? Is it something to do with how it's killing or how long it's active?
Yeah, yeah. The thing is, see, we are not using these mouthwashes to cure COVID patients. What we are
Right.
trying to do, we are trying to reduce the viral load inside the saliva so that it doesn't spread. So we are trying to reduce the transmission. Now, the saliva is always going to be replenished or filled with the virus. Why? Because the virus keeps on coming from salivary glands. It keeps on coming from the lungs. Okay, so your saliva is going to be filled with virus every 2-3 minutes. Now you take any mouthwash, you rinse, certainly they will kill all the existing viruses in the mouth. There is no doubt about it. But your mouth is going to be filled with new load of virus within 2-3 minutes. What are you going to do? Are you going to give the mouthwash again after 2-3 minutes? Now, being a dentist, the patient is on the dental chair for 60 minutes. Does it mean you'll ask your patient to rinse every 2-3 minutes? Means in 1 hour he will have to rinse 20-30 times? No. That's why you don't need a mouthwash that kills the existing viruses. Every mouthwash will kill the existing virus. You need a mouthwash that stays inside the mouth. Even after spitting, it remains in the mouth and can
Yeah.
kill any new virus that can enter the mouth. This is where you require the property of substantivity. Substantivity is persistent attachment to hard tissues and soft tissues of the mouth and sustained release into saliva. And British Dental Journal 1999 has clearly classified the mouthwashes into three groups: Class A, Class B,
Right.
Class C. Class A is the one that has got mouthwashes with substantivity. Means these are the only ones that can adhere to the tissues inside the mouth. And in Class A, we have only one mouthwash, that is chlorhexidine. That's why chlorhexidine is the one that gives stains. So if you
Right.
simply want to know which mouthwash attaches to your oral tissues, you have to just classify the mouthwashes into two groups: stain producing, non-stain producing. So if somebody says my mouthwash doesn't
Right.
give stains, that is because the mouthwash doesn't attach only. No effect, obviously no side effect. It is as simple as that.
True.
And in the
True.
Korean in
So,
the Korean study May 2050, yeah, I
yeah.
wanted to add one more study which gives you clinical relevance. May In the month of May, Korean Medical Sciences Medical Journal came up with this study, published this study which said one single rinse of chlorhexidine mouthwash, 30 seconds, can reduce the viral loads in the saliva for 2 hours. So suppose you have a patient, give chlorhexidine mouthwash at the doorstep only. He'll be on the chair. Even if you treat him for 1 hour, viral load is less. You want more security,
Yeah.
more safety, repeat the mouthwash after 30 minutes. Doesn't matter. But you don't have to give chlorhexidine every 2-3 minutes. And because we know that maximum spread happens while we talk, and patients, while they are sitting in the waiting room, they have the habit of talking to each other or calling somebody on phone. That's when the virus spreads.
Yeah. Yeah.
So
Yeah.
give chlorhexidine mouthwash
Right.
at the doorstep only, and ask them to keep their mobile switched off. You are already
Yeah. Yeah.
reducing the chances of transmission considerably.
Right. And usually in India, a patient is accompanied by someone as well. So, I think it's a great idea to give it to someone who's accompanying the patient as well. That'll also be
Yes,
good.
both. Anybody who enters, compulsorily should be given chlorhexidine mouthwash.
Yeah. Even to our staff.
Yeah, and we see, we are not telling that you don't need PPE, you don't need social distancing, and you don't need masks. All those
Yeah.
things remain as they are. Standard precautions remain as they are. We are adding one additional layer of protection, which is so inexpensive,
Yeah.
hardly takes any effort. Patient has to rinse only once. That's it.
Yeah, that's so true. Uh, so when I use it every day, or if my staff uses it every day, is that fine? Completely fine?
Yeah,
Can I
yeah,
use it
obviously,
over a prolonged?
obviously. Yeah, yeah,
Right.
yeah.
And do
But
right.
some dentists tell me that many authorities, organizations have given their guidelines that we should use povidone iodine and hydrogen peroxide mouthwash. What is my opinion on it? So I always say that
Yeah.
they are recommending povidone iodine and hydrogen peroxide based on some other organization, but they are never saying only hydrogen peroxide or only povidone iodine. So you can
Right.
always
Right.
follow their guidelines, use povidone iodine, but after that give chlorhexidine because it is going to save you. It is going to prevent the transmission inside the clinic.
Right. Right. So the typical mouthwashes that we get, like Hexidine or Hexidine Plus, what is the concentration in that, and do you recommend diluting them when using it, or how
Yeah.
do you suggest?
So
What is your protocol of suggestion?
I have a very simple rule for that. I call it the 10-20-30 rule. 10 means you have to take 10 ml of undiluted, okay, 0.2%.
Right.
That is 0.20% chlorhexidine mouthwash. Rinse for 30 seconds. Keep it preferably undiluted. So 10 is 10 ml, zero point 0.2 is 0.20% of chlorhexidine, 30 is 30 seconds. 10-20-30. Rinse it once and you can reduce the viral load considerably for 2 hours. If you want to, you can always repeat
Right.
it after one.
I was being a little extra careful by making the mouthwash, by asking the patient to keep the mouthwash inside the mouth for at least a minute or two. That's completely fine, right? Or
You can give it like that, but see, after 45 seconds or so, it doesn't make much difference.
right,
So
right.
30 to 45 seconds rinse is good enough.
That's more than enough.
Yeah.
Yeah, that's really good. So I think I'll start getting over that obsession that the mouthwash has to be kept inside the mouth for a very long time, because the rule clearly says that 30 seconds is more than enough. I'm coming to
Yes.
the title of the topic, sir. Uh, you have tweeted this, that your risk of death if you get infected with coronavirus now is probably about half of what it was in March or April. The question is why? Is this also related to the age demographics, or maybe the geographic
Yes.
demographics?
Yes. Very important, because I'll tell both of them. See, we have got, when we are talking about mortality or death rate, we have got two types of statistics. One is case fatality rate. Second is infection fatality rate. Okay, you can
Mm-hmm.
and case fatality rate is how many people die among those who have been tested and diagnosed positive. Okay, so 100 people have been tested with PCR, and out of them, how many came positive, and out of them, how many died. That is case fatality ratio. But there will be a lot of people who remain asymptomatic. They don't even come to know that they are infected. So that number is much, much
Mm-hmm.
bigger. So out of that,
Okay.
how many people will die? That number will be even smaller. So that is called as infection fatality ratio or infection fatality rate. So
Mm-hmm.
IFR, infection fatality rate, is always much, much smaller as compared to case fatality
Yeah.
ratio.
Mm-hmm.
Okay.
Mm-hmm.
So now this case fatality ratio or infection fatality ratio, you cannot have a universal number, because it varies from age to age group to age group. So if you
Mm-hmm.
consider an age group of above 70 or 75, the number will be much higher.
Mm-hmm.
As you come downwards, lower and lower, younger age groups, these numbers will be even lower. So
Right.
evidence-based medicine has given us clear-cut numbers that in geriatric population, higher age groups, the numbers are always going to be more, and in younger population, it is going to be less. And
Right.
maybe because higher age groups, they already have some comorbidities. They also have something called as basal inflammation. Your body is already inflamed for no reason,
Mm-hmm. Mm-hmm.
so it overreacts. That's why higher age groups are more prone to medical complications as compared to younger people. And younger people, if you take kids, children, they are already fresh. They have very recently taken their other vaccines. These vaccines
Right.
give one or the other type of non-specific protection. So because of these things, the elder age group are more prone, younger age groups are less prone. But when it comes to what this mortality ratio was 6 7 months ago, it has improved considerably, mainly because we have now classified the
Mm-hmm.
disease differently. We have different markers, and see, the number of patients we have treated now is in millions. So there is huge amount of data. So doctors have
Right.
realized what mistakes they were doing earlier and which mistakes to avoid now. So they know in the early
Mm-hmm.
phase of the disease which medicines to give, which ones to give later. What is the difference between ventilation, okay, ventilator support, or what is oxygenation? How to give steroids, okay, and
Right.
when to give steroids, for when it will help. All these, and when to give anticoagulants. These things have taken the recovery rate much higher, and they have brought down the death rate much lower. That's why, and infection fatality rate, which I said, that is less than
Mm-hmm.
1%. It might be around zero point 0.5 or zero point 0.6 now. But zero point
Right.
0.5 and zero
Right.
point 0.6 is out of 100. And looking at the number of people, millions of them, if you multiply it with millions, the number of deaths that has come down,
Mm-hmm.
that number becomes very huge. Means we have made significant progress in reducing the number of deaths. But we have also realized that death is not the only thing. Many people suffer with long-term complications. Many people have long-term suffering because of COVID, which is called as long COVID. So some people might suffer
Yeah.
from
Yeah.
cardiovascular. symptoms for long period of time. Sometimes some people may have fatigue for long period of time. So among all the symptoms that remain for longer period of time, fatigue is the commonest.
Mm-hmm.
And cardiovascular also is there. So that's why we suggest that if you are
Right.
an athlete or a sports person, see, athletes are always eager to get back to their sports routine,
Right.
and their heart might be still weak inside. So the best precaution for them should be not to strain themselves too much and take rest till more evidence comes that okay, if you are an athlete, take rest for 3 months or 6 months, whatever it is. But till then, take rest. Don't unnecessarily stress yourself.
Right. So, are you suggesting that uh, COVID 19 is not primarily lung related or pulmonary related infection? It could be a multi system disorder.
Yes, yes, yes. Multi-system. Now everybody has got his own genetic predisposition. Okay,
Right.
genetically
Right.
prone to develop different
Mm-hmm.
comorbidities. Somebody has got weaker cardiovascular system. Somebody has got lung illness. Okay, so based on their own genetic predisposition, long COVID symptoms may remain there for a longer period of time in those weak systems of individual. Varies from person to person.
Right, right, right. So, since we are talking about risk factors, there's always a risk difference between individuals, like the way you said. While some of them
Yeah.
are particularly prone to a particular disease, some of them are naturally immune in terms of the symptoms, at least that they show. Can you give us a rundown on all the risk factors that you taken into account? Like some of them, can it be regulated or can it be fixed? Like, is there a genetic predisposition, stuff like that?
Yeah, yeah. See, there are some risk factors which we cannot change at all. For example, if you are an aged person, you cannot reverse your age. So you already are in that high risk bracket. Second is gender. If you are a male, you are more prone to more prone to medical complications
So
because
bad,
of COVID.
bad
Yeah.
news for men.
Yes. Age and gender, age and gender are always, they are fixed factors. The third one you can say, recently they have come up with this evidence that people with Neanderthal genes, okay, Neanderthal gene increases your risk, okay, towards
Mm-hmm.
medical complications. And they have also come up with this statistic of South Asian population. This much, this many percentage of people have this Neanderthal gene. In Europe, so many people have this. It's in early stages, but we have got some idea. So genetics, age, and gender are three things which we cannot. And also there are some other things like, as I told just now, many people are genetically prone to weaknesses in different systems. Somebody is genetically prone to develop complications in cardiovascular system. Somebody has weak heart. Somebody has got poor gastrointestinal system. Somebody has got weak respiratory system. So these are genetically determined. So we cannot change these also. And
Mm-hmm.
there is one more thing, if I can add, which you cannot control, is our prior exposure to other coronaviruses. For example, common cold viruses are also coronaviruses only, but different family.
Mm-hmm.
Now,
Mm-hmm.
somebody who has got his prior exposure to common cold coronaviruses will have some immune recognition. I'm not telling they are protected. Okay, so somebody who is prone to getting common cold
Right,
again and
right.
again, he may not be protected by SARS-CoV-2, protected from SARS-CoV-2, but some kind of connection is there. So at least immune recognition, immune memory is going to be there. Many more studies are going on. So in the next few months, we may have more data on how our pre-existing immunity, especially the T cell based immunity and innate system immunity. So people who are watching this program and who are novices, who have very little idea about immune system, I just want to make it very, very simple. Immunity is not just antibodies. It could be innate system, which is very, very basic system. And second is adaptive system, in which we have got cellular immunity, which is T cell, and there is humoral, which is antibodies. So all this while we have been focusing only on antibodies. Now, as
Mm-hmm.
we are coming up with more and more data about innate, for example, in which interferons act, and then we have got cellular immunity where T cells act, these are going to give us a lot more idea in the coming few months or years about our pre-existing immunity to SARS-CoV-2. That's why if 10 people are infected, not all of them get severe disease. Many of them hardly get any disease. So these are the factors. Now I have just told you all those factors over which you don't have any control. What about those things over which
Right.
you have control? I can tell two factors. One is vitamin D levels. Your vitamin D levels have to be optimum. I'm not saying you should overload yourself with vitamin D. You should have vitamin D just enough to prevent the deficiency.
Mm-hmm.
And
Mm-hmm.
second is your obesity. Your body mass index should not be much more. So
Right.
if everybody wants to remember one magic number, remember 25. What is 25? Your vitamin D levels should not go below 25. Your body mass index should not go above 25. But if you maintain this, you are doing well. So remember 25. So of course, vitamin D I'm talking about nanograms per ml.
I'm trying to maintain as I talk to you. So yeah, we all know that vitamin D is largely deficient because a lot of people are staying indoors. So for people who do not know, vitamin D, I think is available in two formulations. One is 2000 units and one is 60,000 units. So the
Yeah.
60,000 one, you can have it weekly or once in 2 weeks and stuff like that, but consult your physician and then
Yes.
have it. So
Yes.
there are some
Yes.
tablets which you can have every day or every 2 days, but there are some of them, they are available in capsule form or they are even in the chewable form. You can just keep it in the mouth and it works. So I have it like once in a week since the pandemic has started. Since we are
Yes.
talking about drugs right now and we've just shifted from immunity to vitamin D right now, would you say that HCQS and vitamin D has helped in preventing the infection in the current situation?
Yeah, yeah. We have got multiple studies where they have shown that people who had optimum level of adequate level of vitamin D levels in their body, they have suffered less complications, and even the death rate has been less. So we have enough number of studies for vitamin D. And which one you said? The other one, HCQ, hydroxychloroquine.
Hydroxychloroquine, yeah, yeah, hydroxychloroquine,
Yeah,
same.
yeah. Hydroxychloroquine. There are many studies. Currently,
Mm-hmm.
ICMR and AIMS are still continuing, going ahead with their earlier recommendation of pre-exposure prophylaxis. They are not telling you hydroxychloroquine to people who are already admitted in ICU. They are telling that pre-exposure prophylaxis,
Mm-hmm.
if being done, it will prevent you from getting infected and it reduces the complications. This is what they are telling. So those guidelines are still valid. Of course, there are some randomized control trials which have said that people who are already admitted in the hospital may not be so benefited with hydroxychloroquine. But since our Indian recommendations are still on, doctors should continue to take it.
So am I included in that list of pre-exposure? Because I'm a dentist, there's a possibility
Yes.
that I can get exposed. So should I start consuming it once in a week?
Yeah, yeah, yeah.
I
As
can.
long as ICMR is recommending, AMC is recommending, you should go ahead with it. And of
Right.
course,
So
some state governments have replaced hydroxychloroquine with ivermectin also. So you can choose one of them.
right. So I am having HCQS once in a week. That's 400 milligrams. So I can either you can have one dose in a week or you can have two doses in the same day. That's 200 milligrams.
Yes,
But that's just once in a week. But it's important. Right now we are talking about HCQS, but it's important that even this medicine, sorry, has to be taken under the supervision of your physician because it does not go down well with cardiac patients. So whatever that we
yes,
are discussing in today's session, don't just consume it blindly. I think it's very important that you consult your own physician and do the needful. Right, so we
very true,
jump
very
into HCQS and vitamin D because we are talking about T cell immunity. And we've already seen that uh, the infection is changing the ratio of the white blood cells. And I think you've made a very interesting video on early diagnosis of the disease, which is also having the blood cell count into consideration. And I happen to, just stumble upon a video that you had made. It was a doodle, I think, that you had made. And I think it's
yes.
a good time to share it with our audience if you give me permission for that.
Yeah, yeah.
Can I share it with the audience?
Yeah, please. You saw it on YouTube?
Right. Yeah. Yeah, I saw it on YouTube. I'll just play it for everyone. Are you able to see my screen, guys?
Yeah, yeah. Audio is not audible.
Okay, just one second. All right, I'll just try to play it again by removing my headphone. I hope it works now.
Do you realize why precious lives are being lost
Is
daily
it
from
audible
COVID
now?
19?
Yeah.
Just because we ignore its early warning signs. Success of COVID 19 treatment solely depends upon its early detection. First week of symptoms is critical. Because of our fear, denial, home remedies, and self medication, we lose crucial time. If you develop symptoms like fever, cough, weakness, etc., monitor yourself right from day one. And monitoring is as easy as ABC. What is ABC? It's a three-step protocol that has saved many lives. A stands for air or oxygen. Check your oxygen levels daily by putting a pulse oximeter on your finger. If the number goes below 94 and starts approaching 90, don't wait. Move to step B. B is for blood. If your blood report shows less than 20% lymphocytes and the neutrophils are 4 times higher than lymphocytes, jump to C. C is for chest. Get a high resolution chest CT scan done and look for opacities. They show the disease severity. A positive report with high score indicates lung involvement from COVID 19. Contact a COVID hospital immediately for treatment. ABC is very simple. Please remember to use the ABC protocol to save yourself and your loved ones from COVID 19.
Yeah, that was perfect. Was the audio audible after that? After
Yeah,
I
yeah,
remove
yeah.
my headphones?
Yes, yes. Very
Okay,
clear.
cool. Cool. I'll just put my headphones off. One second. Am I? Yeah. Yeah. Am I audible now? The video was audible, right? So that is a very simplified version of people to understand how do we go about diagnosing the disease by ourselves. And it was really, really good, very well put forth. And I think that video is just 90 seconds, right?
Yeah, yeah, yeah. See, what happened is all evidence tells you only one thing. The earlier you detect, people who get it detected early, who start receiving the treatment early, they have very high chances. They don't require many medicines. They don't develop complications. The more delay you cause, so many problems occur. So early detection is the key. So don't ignore, don't try out home remedies. Okay. So inform your doctor. That is the best thing. Or if you want to follow yourself at home, buy a pulse oximeter. If the number goes below A for air, oxygen, if you find that your oxygen levels are less than 94, jump to B, simple blood test. If your lymphocyte levels are low, see, COVID 19 is known as the serial lymphocyte killer. So if you have COVID 19, your lymphocytes will already be low. And at the same time, neutrophils will be higher compared to lymphocytes. How much? Neutrophil lymphocyte ratio will be 4 or more. So now B is also positive. Jump to C. C is chest CT. Look for opacities. If your opacities are also there, the imaging center itself will tell you that this much score means this much complication. You directly start taking your medical treatment. So the earlier you started, very good prognosis, and you can save lives. So in fact, I suggest learn this ABC protocol, teach everybody because every life
Right.
matters.
Right. So I think I'll be more than happy to share the link of the video with everyone. If people want to know the link, I can just paste it on the comments. I'm going to be doing that now.
Yeah,
So I'll move on to the next question and I'll be putting that in the comments later on.
yeah.
So our concern in the dental practice is that the infection must not be transmitted. That's all, irrespective if it's from the patient to the dentist or even vice versa. What test would help us decide on whether the patient is infectious or not? Because that is the thing that really matters. So, do we have a practical and available access to the test that helps us in the process? Do we still have it?
Yes. See, as you defined it very well, dentists don't have to check who is infected. Our dental
Right.
clinics are not COVID centers. We
Yeah.
just want to know who the patient enters the clinic, whoever enters our clinic, does he have the risk of transmitting the virus when he is inside the clinic? So we know that there are people who can be COVID positive but may not be transmitting the virus. So you need to identify who transmits the virus. COVID positive, that status will remain for many weeks. For 5-6 weeks, the person may still continue to show COVID positive. That is not our concern. Our concern is whether he can spread the virus. So for that, you just need an antigen test. So we are not checking the infection status, we are checking the infectivity status or infectiousness status. So for that, you just need antigen test. So there are many people who say, no, antigen test is not so sensitive, as sensitive as RT-PCR. And even if antigen test comes negative, you have to repeat RT-PCR. This whole argument is for infection. If you want to identify who is infected, then you have to repeat the RT-PCR. But if you are a dentist, a patient enters, you do antigen test, and he is negative, there itself you come to know that this person may be positive, but he will not spread. For dental clinic spread, the risk is zero. You can easily take him inside and start the treatment. And of course, you are wearing PPE, you are also giving him chlorine mouthwash, you also have your HEPA filter and all other air changes per hour protocols in the clinic. There is a window open, all those things you are doing. So like Swiss cheese model, when you are doing multiple layers, you are doing antigen test positive, antigen test, whoever is positive, send him out then and there only. You don't need anything else. So antigen test positive doesn't require an RT-PCR confirmation. Antigen test positive is as good as PCR positive. He is risk. He's carrying the risk of spreading the virus. So you send him out from there itself. If he is negative, there is still a chance that he might be PCR positive. He might still be infected, but it doesn't matter because he is not spreading to you. So you can take him inside. Now you do the second level, that is giving chlorhexidine mouthwash. You can repeat. For you, every patient is infected. Just like we are all well versed with dealing with HIV positive. For us, every patient who enters the clinic is an HIV positive. That is our infection protocol, disinfection protocol, whatever you say. Similarly, any patient who enters the clinic, consider him as PCR positive. Only question is whether he is antigen positive. You have to check that antigen test. But unfortunately, these tests are not available as of now in private pathology labs. They are available in government facilities for free. So you can send your patients to get the antigen test done, and if the test is result is negative, you can treat him. But remember that all these things are valid time bound. So that test the results are valid for that day only. Because next day the viral load may increase from 10 raised to 3, it may directly jump to 10 raised to 6. So if you have got your second sitting of root canal treatment tomorrow, your patient will require another round of antigen testing. So pandemic control is not about having a highly accurate test. It is having a low sensitivity test, but which is high specific. Antigen tests are low sensitive, but highly specific, but doing them frequently. Frequent testing is the key to reducing the pandemic severity. But now that Feluda is coming, CRISPR-based test, it is going to be available in the next few weeks. Maybe I think in the month of second half of November it should be in the market. So you can get all your patients tested with, and you can use saliva also. CRISPR test, Feluda test allows you to take saliva. So you need not be an expert in taking swab only. You can take saliva-based tests. Can I share a slide?
Yeah, sure, please.
I'm sharing the screen. I'm showing you
Yeah.
one slide.
Yeah, it's visible.
Are you able to see the slide?
Yeah.
Slide is visible? Yeah.
Visible.
So I am a big proponent of saliva-based tests because saliva-based tests are now as sensitive as swab-based tests, and you don't require a highly trained person to collect the swabs. Okay, saliva is just patient has to rinse with water and spit in a test tube. Now you have got three types of saliva-based tests. There is saliva-based PCR alternative. Okay, so this is something called as Handifuge. being prepared from released by Stanford University. If you can see the high sensitivity values here, these are good enough for us. Okay, positive test agreement is nearly 90%, negative test agreement is almost 100%. And coming to saliva based antigen tests, Becton Dickinson is coming up with their own antigen tests, saliva based. See the specificity, 100%. This is what we need. Sensitivity is also decent. So anybody who tests positive, you don't take him inside, you are already safe. And then we have got saliva based CRISPR test. This is our Indian Feluda test. Okay, see the values, mind blowing. Specificity is 98%, sensitivity is 96%, and very, very economical. Okay, less than 1000 rupees or 500, you never know. So these are going to be game changers. And
Right.
a few things which
Right.
I told earlier was this. Okay, infection. 50% patients don't get symptoms at all. 50, only remaining 50% remain, develop symptoms. Out of that, 80% spontaneously recover with mild to moderate symptoms.
Mm-hmm.
20% of them develop severe symptoms, which may have to be admitted in the hospital. Out of that 20 also, 85% means 85% of them recover on their own. Out of remaining 15%, that is out of 100, only 1.5 remain. Out of that 1.5, you have got recovery here also from ICU, and only one person dies. So out of 100, only one person may die. This is the number we have. So
Mm-hmm.
these numbers are
Mm-hmm.
very, very critical because you should know the statistics.
Mm-hmm.
And
Mm-hmm.
anything I had to show earlier, these are the curves that I said, saliva tests. As I told you, the risk factors that are under your control. Obesity, keep your body mass index less than 25 and vitamin D
Mm-hmm.
levels above 25. Then you are safe.
Hmm.
And this is our ABC, my ABC protocol. Tests are your
Right.
antigen test, RT-PCR test, antibody test, etc. Symptoms are your cough, fever, body ache, etc. But my ABC protocol doesn't depend on these tests, doesn't depend on the symptoms. My protocol is entirely dependent on science. How much is your oxygen saturation? What are
Right.
your blood differential count levels? What is your CT scan opacity? So my entire protocol is sign based so that you are not confused by the symptoms, nor you have to depend on the delayed test. You can be empowered on your own. You can get your investigations done.
Mm-hmm. Mm-hmm.
So keep a pulse oximeter with you. Very simple. The reading itself tells you. But you should use your dominant hand. If you're a right-handed person, use your right hand and use it on the middle finger.
Mm-hmm.
Okay. All right. I'll
Right. So
I'll stop sharing.
we can proudly show the middle finger to the pulse oximeter.
Kind of, kind of.
Right, right.
Yeah.
So, since we are talking about the test, I think I want to understand the cycle threshold value a little bit more because I couldn't understand it in your previous lectures. Can you explain a little bit about it and why we should take it seriously? Is
Yeah,
it
yeah.
related to that same thing that we have to test frequently stuff?
Yeah, see, cycle threshold is the number of amplification cycles. How many amplification cycles you have to run in your PCR to detect the viral RNA? Means what?
Mm-hmm.
If you have to use more and more number of cycles, means what? That person has got very low viral load. Now, if the default value of your PCR is 37 or 40, it means what? You have to keep on running your PCR for 37, 40 cycles till you get that, amplify it and detect it. Means what?
Right.
You are detecting a lot of people who have got very little viral load. That's why so many people don't even come to know that they have a virus inside. And so many people have,
Mm-hmm.
they get infected, they get diagnosed also, but they have got very mild symptoms. That's why viral load is very, very important. Now, there are certain
Mm-hmm. Mm-hmm.
numbers. This number understanding is very important. All we need to know is at what number the person can spread to others, at what number he is more prone to complications of COVID-19. So a
Mm-hmm.
lot of studies have shown that if the cycle threshold value, CT value of PCR is 24 or below,
Right, right.
then the person is prone to three things. He can infect others because he has got much higher viral load. Second is if he is admitted in the hospital, he is prone to medical complications. Plus, lower viral load, mortality rate is also high. And if you see the CDC experiments, even their website tells you that if your CT values are higher than 35, okay, 33, 35, it is very, very difficult to culture live virus from there. See, this is very important. What are you detecting ultimately? Your PCR is going to detect just the RNA fragment. What is risky? Having an infectious virion, something that can infect others. So people who have got high CT numbers, if your CT value is very, very high, means what? Your viral load is very less. Live virus cannot be isolated from those people. Whereas if your numbers are less than 24, for example, if your CT value is 23, 22, then there is a very high likelihood of live virus being present. That's why you can infect others. That's why we should start making use of CT values. ICMR has the same old notification even now that there is no correlation, but we have got a lot of evidence in the last few weeks, and it is time that ICMR changed their guideline.
Right, right. So we are moving on to the last 10 minutes of the session with Dr. Rajeev Chitguppi. So if you, I'll just request the audience, if you have questions, just start posting on the comments wherever you are on Facebook, YouTube, or Twitter. So I'll move on to my next question. Um, have you noticed any correlation between the other vaccinations? I'm not speaking about the COVID vaccine being developed or not right now because I know it's going to take time. But is has there been a relationship between vaccines like MMR or even BCG and the incidence of COVID signs or symptoms in those kind of patients or people who've taken those vaccines? Is the incidence less or the symptoms are much milder or something like that?
Yeah, see, there are people in India like Dr. Govardhan Das who has been talking about the effectiveness of BCG vaccine, that it may provide protection to people who have taken BCG vaccine. And we also have some evidence for MMR vaccine, mainly the
Sorry.
mumps.
Mm-hmm.
The, the principle is the mumps virus has got a molecule called as neuraminidase, or in short, NA. So mumps virus has got neuraminidase, which is in one or the other way similar to the spike protein of SARS-CoV-2. SARS-CoV-2 uses spike protein to attach to host proteins, host receptors, and gain entry into the body. Similarly, mumps virus uses neuraminidase to interact with the host protein, host receptors, and gain entry. So what mumps vaccine does is it acts against the neuraminidase.
Right.
Now, because neuraminidase is similar to spike protein, there is a hypothesis that people who take MMR vaccine may receive some similar protection against SARS-CoV-2 also. But we need more data. A lot of trials are ongoing, and I am alert watching all those trials. So as soon as I get
Absolutely.
some data on that, I'll be posting them. But there is, yes, this is a very important question that you have asked. MMR vaccine definitely has a role. We just need more data whether it actually gives active protection, whether it correlates of protection are very high with MMR vaccine. In that case, the biggest problem is solved because MMR vaccine is so harmless. You can just give everybody one more round of MMR vaccine. The whole country can be vaccinated at no extra cost.
And there's one more interesting thing that I found out when I interviewed one of my friends. He's a pulmonologist, and he specializes or he takes an extra effort to treat tuberculosis patients. So he had a story to share that when the pandemic actually started, and since he was in charge of the tuberculosis patients, so they were really worried about co-infection and he was really scared what is going to happen, because these patients would be more susceptible. That is what they had thought of initially. But as the time progressed, the cases were increasing a lot outside, in the outside world. But these close group of patients who had tuberculosis, or who were vaccinated, um, or who are being treated for tuberculosis, the incidence of COVID 19 was strikingly less in those cases. So there's definitely some correlation that's going on, which we had not expected in the past, but it's becoming more and more clearer as the time is passing. So there's something definitely going on with respect to the vaccinations that we have taken when we were younger or kids. So that's something that I also wanted to share. Right. So we are almost coming to the last question, and I wanted to ask about uh, herd immunity or lockdowns. Is that a flawed paradigm? What is your opinion on this entire concept?
Yeah, see, herd immunity, in the beginning, we all thought that more and more people get infected, they all develop antibodies, and the whole community, there will be a certain amount of population that develops antibodies, and automatically the spread of virus will be stopped. And as we got more and more data, we realized that at least 50% of the population has to be infected, and at least 50% of the population should have developed antibodies in order to protect the remaining 50%. And this 50% is very huge. And till now, we have not been able to achieve that 50%. And how much have we achieved in India? ICMR has done different seroprevalence studies in Pune, Mumbai, Delhi, etc. The numbers are varying 10%, 15, 20, 25%, and all that. Very recently, last week, we have got report from Wuhan, the epicenter of COVID-19, and they did the study and they tried to identify what was the seroprevalence, how many people have developed antibodies, and that, if you call it herd immunity, it is less than 5%, 3.9% to be exact. It means what, even in Wuhan there is a huge, large chunk of population that still needs to get exposed, get infected, and develop protective antibodies. So herd immunity is not a good plan in these cases. And of course, herd immunity as a concept was introduced as a tool in vaccination planning. It was never a strategy to expose the population like herd. Humans are not herds. We cannot expose them to get exposed so
Right.
that some of them will die and remaining will will remain. That is never a strategy. That's why herd immunity is not a strategy anymore.
Mm-hmm.
And you need to say any which way. We have already reached 90% of recovery rate. That earlier fear of COVID-19 has already reduced. Another 4 or 5 months,
Right.
I
Right.
think Indian doctors will take the recovery rate almost to 100%. And we'll have many more trials that are aggressively going on. We'll have more data, better molecules, better antibodies. And before even the ultimate aim of vaccine is achieved, we'll have many other things by which we'll be able to, make people overcome the threat and reduce the long-term complications also. For example, we'll be able to reduce the duration of long COVID symptoms also.
Right. Right. So in short, what you are saying is herd immunity was never a strategy. It's an outcome.
Yes, yes,
Yeah.
yes,
Yeah. Yeah. Right. Great. So I think I'll start taking questions from the audience now. I'll just put it up on your screen. So Dr. Padmanabhan Yuvraj from Coimbatore. Hi Padmanabhan sir. Can we assume that a person with high viral load has greater chances of developing profound fibrosis of multiple portions of the lung? I think this was also one of the questions that I also wanted to ask. But what is your opinion about
yes.
that? So.
Yeah, see, the thing is, viral load is connected with infectivity as well as people have developed more chances of more likelihood of developing complications. So
Mm-hmm.
going by that rule, there are greater chances of developing profound fibrosis of multiple portions of lung if the detection and medical intervention happens later. But if you have
Mm-hmm.
got high viral load, but you get it detected very early,
Mm-hmm.
the day you got the first symptom, from that day only you started monitoring yourself and you got the necessary investigations and you got started with the intervention, then even with
Right.
very low CT value, that is even with very high viral load, you will be able to prevent lung fibrosis.
Right. And
So
I can see
timing
that you
matters.
had already
Timing.
tweeted about it on 18th of October. I'm not really sure if you can see my screen, but you've tweeted this on 18th October that early in the pandemic, the doctors were thinking that it could be an irreversible damage leading to lung fibrosis. But the situation is not the same anymore, and there's definitely signs of reversible damage.
Yes, this was one of the very good news that we heard in the last week. That even in those cases where we thought there are no chances of lung recovery, people have started showing lung recovery spontaneously. You have to just give time. You have to just give time.
Right, right, right. Yeah, so I'll just put up the next question is uh, is about HEPA filters. Do you want to answer this, sir? I think already people
Yeah,
are using it.
and apart from see, we have got three types of things. One is we protect ourselves with personal protective equipment. Second, we take precautions for our patient. That is, we do antigen test and fluorexidine. And then we have got environmental modification also. Like air circulation is ventilation, and air circulation is of great importance in environment modification. You know, and in that either your windows have to be open, or if you are running your
Mm-hmm.
AC, your air has to be directed towards one source which will attract everything. So you can keep
Mm-hmm.
your HEPA filter and you can use your fans, pedestal fan behind you. Your dental operator keep the fan behind you so that the air is pushing everything. Whatever aerosol is coming out of patient's mouth is being pushed towards the HEPA filter, and there can be an exhaust also which can push it further towards the HEPA filter. So HEPA filter, mandatory or not, I cannot say, but HEPA filter definitely helps. If you don't have windows,
All right.
if you don't have windows and there is no cross ventilation, it is better to have HEPA filter. And of
All right.
course, the
So
risk of dental aerosol is almost reduced now. Okay, we used to think that every
yeah.
aerosol is risky, but the aerosol that
Mm-hmm.
comes out of your body directly, either by coughing or talking
Mm-hmm.
or by medical aerosol procedures, they are risky. In dental aerosols, already
Right.
you are mixing, so much of water. Most of it is water, so you don't have to worry much.
Right. So even I would want to specify something at this point of time. It also depends upon the rubber dam use. So I have changed a lot of my protocols recently. For example, if I had to start, so if I had to do a root canal opening, first I used to do the opening without the rubber dam, and then I used to put a rubber dam, and then start because it was a little bit easier for me. But since the pandemic has started, I put the first thing that I do when the patient comes in is put a rubber dam, irrespective of what the procedure is. Also, obviously, apart from extraction or
Yeah,
scaling.
yeah.
So
Most
I
of
think
our
that also
dentistry,
helps a lot.
most of our dentistry is restorative dentistry. And the moment you use rubber dam and high wax section, most of the aerosol concerns are over. So you don't even need an extra oral suction for that.
Yeah, yeah. So I think a better thing, Deepika, would be to learn how to put a rubber dam faster and start using it for all the cases. And maybe HEPA filter, yes, but more important would be rubber dam use. Right. So the next question is by Harit. So is there any connection of COVID infection with heart rate and blood pressure?
People who have got hypertension, people who have got their pre-existing cardiovascular
Yeah,
comorbidities are more prone to
yeah.
COVID-19
We've
complications.
already answered
And
that.
we have
Yeah.
also come to know that there is a what you can say cardiomyocyte. The heart cell is called as cardiomyocyte. There is a cardiomyocyte damage that occurs in because of COVID-19.
Right.
Okay, that's why we need to wait for some more time for the heart cells to recover. So there is definitely a connection between
Mm-hmm.
heart rate, blood pressure. So cardiovascular predisposition is definitely connected with COVID-19.
Right. So this question is there. What about flu vaccine? I'm not really sure what that question means. So I'm just going to jump on to the next one.
Flu vaccine. I think he said whether flu vaccine helps us with COVID-19. The thing is, just like I told you, flu vaccine is not a specific vaccine for COVID-19. Just like mumps or MMR vaccine also, they are not direct vaccines, no specific vaccines.
Hmm.
MMR vaccine gives you some non-specific protection because the protein similarity is there. Neuraminidase is similar to spike protein, but flu vaccine doesn't act on this specific molecule. Flu vaccine acts on some other molecule, doesn't act on spike protein at all. So flu vaccine doesn't give you any protection against SARS-CoV-2. You have to Pavan Kumar Addanki, I think, yes.
Right.
So it is the
Right.
molecule on which it acts.
Yeah.
So any molecule that is specific, similar to spike protein, it will give protection. But unfortunately, fluoxetine acts on a molecule which is not similar to spike protein, not on spike protein. Is
Right.
it
Moving on to the
safe
next
to,
question, sir. Yeah, ultrasonic scaling in the hospital
because it,
setting.
yeah, yeah, yeah.
Maximum aerosols.
Yeah, ultrasonic scaling again it's a dental aerosol. Most of your ultrasonic aerosol is water. So and your tap water already contains some amount of chlorine. And you can add some chlorhexidine in your bottle also. We know that
Right. Right. Right.
0.05%, 0.05% is enough to kill SARS-CoV-2.
Hmm.
So in
Hmm.
your 500 ml bottle, you can add 100 ml of chlorhexidine and you can add remaining water. Okay, you can
Hmm.
use this
Hmm.
specific combination for your scaling patients.
That's a very good tip.
Alone. And
Yeah.
along with your PPE,
Hmm. Hmm.
HEPA filter, etc., I think the risk is minimum. And as Mayur, you must have read the recent
Right.
report. Less than 1% of dentists have got infected because of the COVID-19. So it's not
Yeah,
a
yeah,
risk
yeah, yeah,
anymore.
yeah, yeah. I wanted to, yeah, I wanted to take up that question, but I think the time is limited, so I've started off with the audience questions. And but the other thing that you suggested is more important is the question is about a hospital setup, so maybe a college and stuff like that. So what you suggested that chlorhexidine should be added in that water is going to be a really helpful tip because maybe the question was related to the students or postgraduate students over here. That's what we see a lot in the hospitals, right?
Yeah, yeah. Initially, my first article that went viral was that only. I had
Right, right.
suggested adding povidone iodine into the water bottle because adding povidone iodine into the water bottle was one of the established protocols in perio. So you can add povidone iodine or chlorhexidine. Chlorhexidine is even
Mm-hmm.
more potent. So in the ratio of 1:4, you can add, and it can reduce the viral load. Can we take up elective surgical
Right, sir.
cases like implant surgeries after thorough preventive and precautionary protocol for like after antigen test? If you do antigen test, if your antigen test is, if the patient's antigen test is negative, it is as good as a
Yeah.
safe patient. You can do anything in that patient. You can do ultrasonic scaling also. If your antigen test, if the patient's antigen test is positive, then send him out only. If he is negative,
Yeah.
risk is. And again,
Right.
you can give him mouthwash, add mouthwash to the water bottle. Okay, use rubber dam, high vac section. Do all, do everything possible till we have more evidence.
Right. Right. So there's another question by Pawan.
How
So
Sweden was succeeded without lockdown. Sweden has not succeeded in lockdown at all. Okay, herd immunity, it depends on when you at what stage you expose your population. People who have
right.
used expose their population in the beginning, they had tests in the beginning only. What is your opinion about full or half respirators? N95 is not sufficient. Respirators are the best, but N95 is also more than adequate.
Yeah.
There are
But the
no
situation.
studies where it has been shown that people who wore N95, they were more prone, they got more infections. It has not been like that. Yes, in COVID centers where the circulating viral load is huge, that risk is very high. But in dental clinics, N95, you can add a face shield on that. I think it is more than enough. It has been 6 months now. There are a lot of dentists, so many thousands and thousands of them have been using N95 and treating patients, and they have all been doing well.
Right. But in colleges, a lot of people, in fact, a lot of students are still using cloth masks. So that is something that's completely. I think the
Yeah,
students should
so
avoid it under
it
all
is better to use
circumstances.
N95. On top of that, you can use your regular surgical mask. If you can use the respirator, the best. Respirators give the
Right.
best.
Right.
I'm telling you the conclusion of Journal of American Medical Association. Respirators work the best.
Right.
What are the chances of spread of SARS-CoV-2 through clothing, scrubs, or after we fomat transmission? See,
Right.
fomites transmission, surface transmission was an over-calculated and overestimated risk. Okay, so
Okay.
all those experiments which were done, they had used very high concentration of virus in a very very small area. Okay, and those lab conditions, they don't really correlate with real life conditions. So that surface transmission risk and fomitis transmission risk is very little. But if you are wearing regular scrubs, what you can do is you can keep your autoclave open. Okay, you can keep a separate autoclave. As soon as your one scrub is done, you can directly put that cloth in that
Hmm.
autoclave.
Hmm.
So till the end of day,
Hmm.
a
Hmm. Hmm.
lot of scrubs are getting accumulated. At the end of the day, just autoclave everything together. Okay, then you can
Hmm.
take them
Hmm.
home for washing. It is one of the, like, your mind is off. You need not have a tub of
Hmm.
chemical. Like after one patient is done, you don't have to put it in that tub. No, just keep your one autoclave open. Just keep on dumping all your clothes there.
Yeah.
At the end of the day, just run one round of autoclaving. Under
Hmm.
that
Hmm.
high temperature, pressure,
Hmm.
and sustained time, nothing survives. Even bacterial spores
Right.
don't survive. And we are talking about
Right.
SARS-CoV-2, the weakest virus. It will get destroyed in no time.
Right, right. That's so true. So I'm gonna be sharing one more tweet that you had tweeted. Uh, it was about uh, it was about this one. This was on July the 29th. It was about your ABC protocol. Sorry, it was about the 10 20 30 protocol. I hope you can still see the screen, and maybe people who have joined us can take a screenshot of this, because you can just keep that in mind and use it in your clinical practice as well. It's going to be very helpful.
Yeah, yeah. Fluorescence mouthwash, very simple protocol, 10, 20, 30. 10
Yeah, yeah.
ml, 0.20% fluorescein, rinse for at least 30 seconds.
So I think we'll just close the session with another last question by Pawan. What is your opinion about monoclonal antibodies in the treatment of COVID? What is the most
See,
successful drug in COVID
monoclonal
19?
antibodies, we have got three companies that are working. One is Regeneron, second is Eli Lilly, and there is a third company. All of them are doing their trials. Initial data has been good, initial evidence has been favorable. They will be expensive, of course, but let us wait for more trials, more numbers. If it works out, the antibodies will work like antidotes. For example, if somebody is admitted, you just give him one shot of monoclonal antibodies, it will dislodge. For example, SARS-CoV also binds to your host protein, but SARS-CoV-2 binds 10 to 15 times stronger. So you need a very strong antidote or an antibody to dislodge it. So once either Regeneron or Eli Lilly or the third company, any of them works, it will be a game changer. Let us wait for more data.
Right, right. So I think that's all we have time for today. Dr. Rajiv, it was a pleasure and an honor to have you in the session on the first session of day two of the 32-minute podcast launch. It was so nice to speak to you.
My pleasure, Mayur, my pleasure. It was a great session. Thank you so much. And as I told in the beginning, I'm loving this.
It was good. Thank you, sir. Yay. Cheers.
Yes.
Cheers.
And the real session
Cheers.
is pending.
See you. Sure, sir. Sure, sir. I'll see you.
Yeah.
Thank you so much, everybody, for joining us. So I'll see you live again. So it's 1 o'clock now. Our next session will start at 3 o'clock, and that is with Dr. Udatta Kher, who's going to speak on immediate loading, why, when, and how. That's all for this session. Once again, thank you so much, Dr. Rajiv. It was really nice talking to you.
Thank you, Mayur. Thank you, everybody.